Rob, are you ready? I'm ready. Okay, I'll take over. We're going to talk about the extubation of a COVID-19 patient at the end of surgery. A couple things to note. This is the end of the surgery. The incision has been closed, dressings are on, surgical count's done. Nobody else needs to touch the patient other than the airway operators. Because extubation is an aerosol generating procedure, we're going to ask everyone except for myself and my assistant to leave the room. We're going to be fully dressed in our airborne precautions. You'll note that my assistant is also double gloved. I may be double gloved. In preparation for emergence, I may want to consider giving some lidocaine intravenously, or remifentanil bolus, infusion, or converting the case to a TIVA at the end of surgery, just to blunt the cough reflex on extubation. I also want to point out the location of some things here. We have the garbage can to my right and my airway assistant to the left. And the reason why it's like this is so that I have access to the airway and my anesthetic machine should there be an airway complication. My assistant to the left with the mask also has access to the drug cart or any other supplies that I may need. We want to try to be as clean as possible about this, so when I extubate and discard everything, I'm going to immediately take everything that has been in the patient and put it in the garbage can. But bear in mind that if you're throwing something out and you do need something later on, that you should have a backup set available. We have the viral filter. Anything on this end of the viral filter towards the patient is considered dirty. Anything on this side towards the circuit and the machine is clean. I'm using an oral airway as a bite block. So while the patient is deep, I'm going to suction the airway, give my medications to blunt the cough reflex. I'm removing some of the tapes, just in preparation for extubation. It's a good idea to make sure that your patient is on manual or spontaneous ventilation. The patient is meeting all the extubation criteria, including hemodynamics and respiratory dynamics. I'm going to check that he's able to open his eyes and follow commands. If I'm happy with that, then we can begin extubating. I'm going to check with my assistant to make sure that he's ready. Are you ready? I'm ready. Okay. I'm first going to remove the circuit from the Y here on the clean side. That way, if the patient coughs, it's passing through the viral filter. I want to make sure that I'm not doing this, because that way the circuit will blow a contaminated field into the room, or the patient can cough and then that will be expelled into the room. So it's absolutely critical that you disconnect from the clean side. Are you ready? I'm ready. Loosen the tapes, deflate the cuff, everything out. And now I'm discarding the endotracheal tube. I'm holding the viral filter. My assistant has his hand over the hole of the mask, and I'm going to put the viral filter right onto the mask. He's got a good seal. If the patient coughs, again, he's coughing through the viral filter. The wrong thing to do, put your hand back over the mask. The wrong thing to do would be to connect the circuit back on, because there's flow going through this and the contamination is getting into the room. So you want to make sure that you just have only the viral filter with no flow going through it and putting that on the mask. And at this point, I can reattach the circuit. We still have our end-tidal CO2 monitoring. And if we're happy with everything, I can take over the airway. So now that the patient's been extubated, I want to confirm that they're awake, comfortable, and they're back to the baseline respiratory status. So we have two options. One is to give the patient a set of nasal prongs with this procedural mask on top. Okay, go ahead. And a surgical mask. And that's option number one.
If the patient requires medium concentration or a little bit higher than nasal prong concentration of oxygen post-extubation, we have a Tavish mask. This Tavish mask is designed just like a simple mask, but instead of having holes in the mask, it has filters for the expiratory port. Very easy to breathe through.
Okay, good. I'm ready?
Yeah, ready. And then you can mold it to the size of the patient's nose, and the oxygen is running at 6 to 8 liters a minute.